We will start the meeting in just one moment, and it's always a little peculiar trying to, particularly if you're my height, sort of peer over this screen to everyone, but welcome. I think we largely know each other, so it's perhaps worth saying when you start speaking who you are, but there's no need to do a big round of introductions. But for the purposes of the meeting, I'm Roger Goff, Chair of the ICP and Leader of Kent County Council. Can I welcome all those who are attending? Conscious we have a number of apologies, which is regrettable, but I'm not going to read all those out, but I think we have a record of those. We have some people deputising, so welcome to Bissy. We said hello a moment ago. There you are. Welcome to Bissy Dada, who is deputising for Robbie Gotham. To Christine, who is deputising, I think not for the first time. It is the first time? Is it really? There must be other meetings where we see for Anne Taylor. And Caroline, where we spoke again a moment ago. Yes, for Jack, for the local medical committee. I think that's all in the way of... Oh, right, sorry, welcome. Yes, you are not Tim. Pete, very good to see you again. Thank you. Right. We've not yet been sorry? Sorry. Hello.
Hello, Chair. Sorry, it was just to say that my name is Sarah Crouch. I'm a consultant in public health and I'm deputising for Anjan Ghosh, who's the Director of Public Health, who's unfortunately been called away today.
Thank you very much, Sarah. So we've got some items in which Anjan would certainly been playing a significant role. You're going to be covering in those?
I am, yes.
Excellent. Very good. Well, welcome. Thank you very much. And I think that's all in the way of both, as I mentioned, we've got apologies recorded. Welcome to those who are deputising. We believe we are quorate. I think we can have confirmation of that, can't we? Elvira-san? Yeah, I've got a thumbs up from Elvira-san. That's good. We've not been informed of any potential conflicts of interests in advance of the meeting. Clearly, if anyone is aware of any interests they need to declare, please do so now. The register of interests has been attached in the pack at item 3. Otherwise, as I say, apologies will be noted in the minutes. We've covered that aspect. Then, in terms of, we have the minutes of the previous meeting. Can we take it that that was a meeting of 7th of June, that those are agreed as a fair record of that meeting? Is that agreed? Thank you. We have a number of actions. 2 of them are recommended to close. There is one which I've had added subsequent to that, which is that the committee was to write back to the Secretariat on suggested questions on outcome 1. And the response is that Jenny Dixon Sherrard updated this would be addressed as part of ongoing discussions around the ICP's development. So that takes us through, I think there's nothing else from the action log. Am I right, Elvira-san? Yeah, good. Thumbs up again. Excellent. We're doing well. Right, so I think we move first into our first substantive item, which is ICB updates. And I will come first in terms of the overall NHS Kent and Medway ICB report, which is an oral update from Paul. So, Paul, over to you.
Thanks, Chair. So, recognising that this is an NHS Kent and Medway update as opposed to an ICS update, wanted to flag to the committee 3 particular issues. Since we met last time, we have commenced a consultation about primary care in Kent and Medway, and the level of responses has been such that we have extended the period of that. And for the avoidance of doubt, primary care is across the full gamut of primary care, so it's general practice, dentistry, optometry, and the full range of pharmacy services. But I did want to particularly flag that in the last year, we have been able to put 850 additional roles into the primary care workforce through something called the ARRS scheme. Those are things like pharmacists and paramedics and physiotherapists, which is an important part. It doesn't address all the issues, but is an important part of our approach to primary care. and that consultation will close early in the new year, and then we will take that through our governance. Second issue from an NHS perspective is that we've been through a challenging process in the last month or so to make sure that we can manage some of the tensions that are there in terms of the financial position in the NHS and the performance position in the NHS, just to give again the committee a sense of what that means. We have got too many people waiting too long for elective surgery in parts of Kent and Medway, and we're also in a situation where 3 of the 6 NHS trusts and foundation trusts in Kent and Medway have overspent, some of those quite significantly, and we have been going through a process to rebalance both the performance and the finances, and that is a process that is still ongoing. And then finally, just wanted to flag and recognise that this is a challenge across England, but the consequence of ongoing industrial action, in particular as announced early this week by Doctors in Training, where we will have a further 6 days of industrial action this side of New Year's Eve, is a real challenge to health services in Kent and Medway because of the consequences, particularly on elective care. And that's something we've been managing throughout the totality of the calendar year, but it will have an impact in terms of elective patients whose surgery is cancelled or delayed. So just those 3 items, Chair, and then obviously happy to take questions.
Paul, thank you very much. Are there any questions on that report, or indeed anything else related to the ICB NHS Kent and Medway? No? Well, we did say we're not a scrutiny body, so that seems to be being applied very thoroughly. Good. Right, Paul, thank you for that. Right, we move on, staying within this general area, but moving to something more specific, which is an update on the Inequalities Prevention and Population Health Committee and its subcommittees. Vincent, I know you're going to be leading on that, so I will hand that to you.
Thanks very much, Roger. I'm Vincent Badu. I'm the Chief Strategy Officer at NHS Kent and Medway, and I'm the Executive Lead for the Inequalities Prevention and Population Health Committee. The IPPH is a committee of the Integrated Care Board, but alongside that we have 3 subgroups, and those subgroups focus specifically on prevention, health inequalities and population health. The paper that's presented today is really to give this joint committee a flavour of the work that's going through the IPPH committee, and Govinda is the chair of the committee, and my colleagues Anjan Ghosh and James Williams, who are directors of public health for Kent County Council and Medway Council, also chair a subgroup alongside me. What's really important about the work that we're focused on in this committee is that actually we're working across the integrated care system in terms of the membership of the subcommittees, but we really have a strong focus on thinking about how we are delivering aspects of the integrated care strategy, and in particular thinking about how we use the intelligence that we have to really drive our focus around reducing health inequalities, working together around prevention, but also focusing on how we work with other system partners like our colleagues in health and care partnerships and the partners that make up those partnerships to have a stronger focus around the wider determinants. So I think what's important in the paper is to really give this joint committee a sense of some of the granular work that we've been focused on. And what I'm going to do is invite James to talk about the work that the Prevention and Health Inequalities Committee are focused on. And then I'll talk a little bit about the Population Health Management subgroup and the focus that we've had over the last year since those subgroups came into being.
Thanks, Vincent and colleagues. I'm James Williams. I'm Director of Public Health for Medway. I've got a couple of reflections. I mean, the paper is there, and I'm sure that colleagues will have had a chance to read through the content of it. And I just want to articulate, if I might, a couple of key areas. So everyone sometimes thinks about prevention as being the be-all and end-all for everything. It isn't that. What we've got to think about is how effective are our outcomes to prevent things occurring in the first instance. So what we're trying to do with this is set out upstream work, which means that we're working on the wider determinants, and I'm sure that in this committee we've talked about that, and we'll go into a deeper sort of dive when we look at the integrated care strategy. But then there's a focus, I think, on secondary prevention, where people have actually got an existing challenge, and how can we support them to manage those issues. In the framework, in the paper, you'll have read the Inclusion Health Framework and actually the action plan that we've got. We're clearly looking at some of the disease topic areas, in particular smoking, alcohol, drug and alcohol services, and the need to sort of collate those around people who are clearly addicted to whether legal things like alcohol or illegal substances or even over-the-counter drugs, because of the impact that they have on the wider system, and also not just them as individuals but also on their family members. I talk about, or I will talk just briefly about smoking if I might, and you'll all be aware of the government's announcements on the 7th of November to eradicate smoking for a whole generation of our children and people, regardless of what's happened in New Zealand. And I'm looking at our director and our Deputy Chief Exec, Leanne, there. We have still committed within the UK to delivering that ambition. There is a lot of work for us to do at a system level, because we've got to work across our systems with our trading standards colleagues. This is why local government have got a very strong role to play in terms of managing some of the aspects of that, but equally within our NHS space, because our tobacco dependency services delivered by our acute community providers are mission critical for us to actually make sure that we've got touch points and the appropriate pathways for everyone to move in that space. And Vincent's mentioned, the 3 subcommittees work quite hand in glove in relation to that. We've been doing quite a lot of work on tobacco. The challenge that we deep dived into, and we're going to have more work on this in the inequality subcommittee, was cancer. And we received a significant briefing from the Cancer Alliance, just setting out the issues that are impacting on our population across both Kent and Medway. And men, unfortunately, were late presenting. There's a 15 percentage point gap between men and women in essence, in terms of men just presenting late and unfortunately not being able to be as well supported had they come forward a little bit early. So we did a very powerful cancer deep dive. We looked at a whole range of issues, and that will be further unpicked in our meeting with the Inequalities Population Health Committee on the 12th of December. There's some things for us to celebrate. We've touched on the Core 20+5 work, and that's in essence trying to deal with the issues that people have already got. And one of the big challenges that we've got or had across Kent and Medway was hypertension. I'm sure our medical director, Kate, will reaffirm this. The data that we've just had back from NHS England says that we've done a very good job across Kent and Medway in terms of starting to now detect and manage people. And some of the data that we got shared with us last week said that we've saved or prevented 180 strokes and 120 MIs, so myocardial infarctions. Not just preventing them, we've also saved our system of nearly £5 million. That's across health and social care, because those people have not then gone on to require clinical care or care, whether it's in the home setting or in another place. So finally, I think we do know from the work that we're trying to do within the strategy that we've got to get the right outcome measures. So one thing that we have been able to do as a system is to put together a framework for our inequalities across the whole of Kent and Medway. So that's based essentially on the Core 20+5 framework, but it gives us a baseline and a benchmark for us to really then drill down into that and move forward with our action plans against that. So in summary, all 3 committees, both the Population Health Committee, the Inequalities Subcommittee and the Prevention Committee, have clearly got collaboration in mind. We recognise that not one bit of the system can work on its own, and I think just for this committee, it's important when we come on to the debate about the integrated care strategy, we've then got to look at how we all act to support that work, but also are there any gaps that have been identified, and we can clearly talk through that. But with that, I'll take any questions clearly.
Thank you both very much. Are there any questions? Oh, sorry? Oh, Vincent, did you have...
Yes, sorry, Roger. So
sorry,
just,
Vincent, jump in the gun.
to add one final point, which is about the importance of population health management with our focus around how we join up both data and intelligence, but also how we segment our population so that we can really target some of the interventions that we want to put in place. So the point I'd want to make is at the moment across Kent and Medway, we do not have a single way of sharing data across the whole system, but we have been working with colleagues in public health and in other parts of the system to really think about how do we build a system like the Kent Integrated Care Record to enable us to really have information around population at a neighbourhood level, at a place level, and across the whole of Kent and Medway. And again, important within that is how we connect that back to the public health data that we have, but also the information that's available to colleagues within primary care, for example, so that we can really target some of the work that we do in local populations around the things that James has covered in relation to prevention, but also in relation to health inequalities, so that we can see the impact of what we are doing. So again, through the Population Health Management Group, we've been really thinking about how we apply that, how we streamline our approaches, but also how we join up the information and data that's available to us across the system. And again, it's been encouraging to see us take stock of what we're currently doing, but also make some key decisions around what we stop doing as well in terms of the number of systems that we are developing and supporting. And I think the other final point I'd make is around how we make sure that that intelligence is accessible also to the wider system. So importantly, colleagues in the voluntary and community sector, but also working with partners across local authorities in the widest sense in terms of districts and boroughs to make sure that we really are thinking about how we bring that intelligence together to target our interventions, but also measure the impact of what we're doing.
Thank you, Vincent. Yeah, apologies again for jumping the gun slightly there, and we nearly missed out the population health management element. Right, any questions or comments? Angela.
Thanks, Chair. I'd call it secondary, which was one of the things that James mentioned. When you diagnose, okay, you've got that condition, you've got that condition, you've got that condition. It seems that there is a gap which stops any further investigation. I can only speak for people on the Isle of Sheppey that have spoken to me on COPD. Oh no, you've got COPD, that's why you're having trouble breathing. Yeah, but it gets really bad in the summer. Well, you know, this is COPD. No, actually, love, it's probably a pollen allergy that's making your condition extremely worse. But it seems to be, no, we've diagnosed you with COPD, now let's get on with the rest of them. And I think that is missing a trick. That is saying, well, actually, if we looked at the allergy side of it, it might be that we can cut down on your COPD side. But I think we're very fond of putting people in a little box once we've diagnosed them, and anything that comes up, it's that. Now, don't bother me with anything else, it's that. And I think we are missing a trick in terms of the health and well-being of people when we do that. And I've raised COPD, there's a number of other issues that people have raised where they've been put in a box. No, that's that. No, that's that. You know, let's not consider anything else. But you could make their prognosis a lot better if you looked at things which were affecting it, such as pollen. It affects an awful lot of people in this country, but it's put down to, oh no, let's give you some really bad disease. Thanks.
Thank you, Angela. What I'd suggest is I've seen Sedi and I've seen Shane, and unless anybody else is absolutely rushing, I'm just conscious of time. So can I take Sedi, Shane, and then, sorry, Pete, if you wanted to come in as well. Sedi, Shane, Pete, and then Vincent, I'll come back to you to sort of sum up from that, and then I think we'll draw this item to a close. So Sedi, go first.
Thank you. James, really good to hear some of the figures and the difference that the work is actually making to people's lives. Conscious that resources are limited, how are we sharing that information with the wider public, with the voluntary sector, so they can share that information through their networks? Because that might encourage more people to come forward for screening tests and so on and so forth. I mean, great outcomes. We always want to talk about outcomes. I guess it's a challenge for all of us, really, about how do we share good news, really. Yeah,
I'll ask both Vincent and James to briefly comment on any of the points that have been raised. Shane.
Thank you, Chair. And building on that point, I think that is in some way, certainly the point of some of this data should be about how we disseminate some of the good news, some of the stories, how we simplify that. I wasn't going to say anything until James said secondary prevention. It didn't take very long for a red rag to appear for me, thank you. I didn't realise we had quickly moved away from prevention, and now it's only if we can measure prevention that we're actually going to do it, is how that sounded. And I'm sure, James, you could hopefully clarify that's not what you meant, because it goes to Angela's point. We're not going to treat them unless we can put them in the box. We're not going to treat them, we're not going to deal with it unless we can measure it. True prevention, as a bit more a purist, isn't that. People don't need a label to prevent health. If we keep going down the line, we need to give them in a box, we need to share this data, we need to centralise everything, and then we'll be at the centre of this web and we'll share it all. We've missed the point of this entire ICP. We've missed it completely. I've seen some nods, so I don't think I'm alone in that regard. So how do we move away and back to those core principles rather than that level of bar chart obsession?
Thank you, Shane. And Pete.
Thanks very much. Really welcome the opportunity to learn more through a thorough analysis of data and sharing. Seems to me there are multiple forums where these big data exercises are ongoing. I'm sure it's been spoken here and it features implicitly within the integrated care strategy. But it just, I think in the next 12 months would welcome the opportunity to identify through those multiple exercises where we've got overlapping cohorts of high intensity users to be able to really triangulate where the effective prioritization of service delivery takes place, whether that is on a financial footing, whether it might be sort of crime, justice, where it might be health. I think there's real opportunity to be much more prescriptive and joined up in that prevention approach.
Thank you. Some good and varied points made there. Some just fairly quickly, Vincent and James, if you could just come back on some of the points that were raised. Vincent, you first.
Thanks very much, Roger. I mean, if I start with Peter's point, do it in reverse order. So I think this is absolutely why we need to think about how we use the integrated care partnership, but also the delivery vehicles that support the integrated care partnership so that we make that join up happen. There are some existing examples, and you and I know, Pete, there are some good examples of where we've worked together as individual agencies, but it's about how we scale that up and use that data across the whole system. And I think there are opportunities for us to do that, and I would certainly see this joint committee and partnership as an opportunity to do that. But it has also informed the integrated care strategy in terms of how we work around those shared outcomes and how we use enablers like data to support us to get that focus right and to really think about where we make impact, but also change the experience and the outcomes for our population. So absolutely welcome that point. I'll just pick up on the point also about how do we communicate this. So absolutely, we've worked really hard in pulling together the strategy to think about the communications and engagement. And you'll note when we get to the strategy paper that we've moved from having an interim document where we pulled together some work at some pace to really engaging with both stakeholder organisations, but also our population about what we see as the priorities, and supporting that with more detail about what do we currently know and where are the opportunities for us to do things differently. So again, there's more work to do around communications and engagement. That needs to be a continual thread, but we do need to work with all of our system partners, and I would include colleagues like Health Watch to help us make sure that that's a two-way process, that we're getting feedback from people about the balance, but also through our various services, partnerships, to make sure that actually we are sharing what we are doing well as well as where the challenges are. And I think that is something that we all need to be committed to as a partnership. James, I don't know if you want to just pick up on the item about prevention.
Yeah, I'll cover that one off, and also I'll pick up the COPD one as well. So, and Angela, thank you for sharing that. So just reassurance, we've got a project that we're working on at this moment in time for our Health Determinants Research Collaborative Centre to understand why people are presenting with the respiratory issues within the hospital or in other settings, and then to map those out to other factors which could, as you've just described, be environmental issues and factors. So that's piecework that we've actually commissioned, and we're looking at that. And if you notice in the report, talks about some of the work that West Kent are already doing with their housing association in that patch, the HCP. So the wider issues that give rise to why people might do stuff are important to us, and that. But on the respiratory specifically, we're doing a piece of work on that one. The bit that Sedi flagged, yes, is the answer, Sedi. I think we're trying to use, and our comms colleagues, every avenue that we've got to share, whether it's through the socials, because I remember before when we had our workshop, it's, you know, what has the ICB done for us? So that we heard that at the symposium as well. So we will use every opportunity that we can to share good news, and where we, you know, where we're still challenged, I think we've got to be open about that, so we engage our population. It's a great point there. I did actually say, Shane, when I talked, perhaps you didn't catch it, when I talked about the life course. So I'll talk about primary prevention, which is where we're moving upstream and trying to make sure that we do things, but specifically in the report that unfortunately or fortunately, there's some quite distinct areas around access that do link into services, and that's the inclusion health framework, whatever else. So in that, we've got to understand that those people, we need to know who they are, because if we don't know who they are and what is happening to them, we can't then address the inequity which is being faced. And that's why I threw the figure out about men, because that came from a deep dive in terms of our cancer services, which is about access to screening, particularly bowel screening. So the context of, I do hear what you're saying, I'm not trying to funnel people with funnel plots or bar charts or whatever else, but there is a requirement for us to look at the inequity that is happening and occurring within our population, understanding what the causes of those things are, and then doing things to address them. And that's why we're, you know, it is a balancing act, but just to be really reassuring you, the wider determinants, which is what I flagged, is what this partnership is about. The actions that will help to reduce the likelihood of people becoming ill will not be addressed by people, you know, in white suits, and, you know, if they do white suits in hospital settings, we've got to move out, which is what you're saying, so we do treat everyone as an individual if I can. Pete, the data point is really valid. We're working across, and just for information, we're doing some great work with the Violent Reduction Partnership to look at some of that A&E data and other information that we get from some of our services to blend that. So your point's really well made.
Excellent. Thank you. I think we've covered off those points. The partnership's asked to consider and note the contents of the report, which well, we've considered it, and if we could note it, then thank you. And thank you, Vincent and James, for that. So we'll move on. Our next item is the Learning Disability and Autism Strategy 2024 to 2027. Welcome Marie Hackshaw, who I think is going to lead on this item. So Marie, shall I come straight to you?
Thank you. Good afternoon, everyone. I'm Marie Hackshaw. I'm Assistant Programme Lead for Learning Disability and Autism across Kent and Medway. And that's a jointly funded post across the Integrated Care Board, the two councils as well. So I work in partnership with colleagues across all spaces at the moment, which has been really positive for me and for others, I hope. The strategy has come about out of the Learning Disability and Autism Delivery Partnership Arrangement, which is an arrangement that we've had in place now since January 2022 across Kent and Medway, focusing on bringing partners together from both commissioners, providers and the wider community, including people with lived experience, focusing on the areas that we can improve outcomes for people with learning disability and autism in a collective approach and an integrated approach. So one of our priority areas for the delivery partnership for this coming 12 months is to have a strategy in place for people within Kent and Medway who have a learning disability, who are autistic or who have both needs. One of the reasons that we particularly wanted to have a strategy for this population, alongside some of the other strategies that are in place and being developed, is that despite legislation and successive strategies and outcomes for people with a learning disability and autistic people remain quite poor. And in the report, I've added some examples, which are national data, but actually reflect the position that we have in Kent and Medway for this population as well. So we know that people with a learning disability continue to die at a much younger age than the general population. And many people die from avoidable deaths. So in fact, again, thinking about some of the things that James and colleagues have been talking about in terms of prevention and improving the situation for people who maybe have greater inequity in terms of access to services, we could actually prevent a number of deaths happening each year for this population. We also know that many of our population with learning disabilities live in some of the most deprived areas in Kent and Medway, so of course are exposed to some of the social and environmental factors that come into play in those environments as well. And for our autistic population, we know that on average, a person who is autistic will probably die 16 years earlier than the general population. And people who are autistic without a learning disability are currently 9 times more likely to die from suicide. It's one of the highest causes of death for this population. So again, it's an area that we're really keen to start to focus on and improve outcomes. And finally, just in terms of other opportunities for this population within Kent and Medway, we know again that autistic people and people with a learning disability have very low employment rates, again, looking at opportunities about how we might improve those circumstances for people, because we know that being in employment brings all sorts of benefits, both from a health and social point of view. So that's what's driving us to have a much more of a system-led approach in terms of our strategic thinking within the learning disability and autism space, and obviously aligns quite strongly with the outcomes, shared outcomes within the integrated care strategy that I know you're going to talk about a bit further this afternoon. So just a few things in terms of what the strategy aims to prioritize over the course of the next 3 years. We're looking to aim to bring the system together to deliver on some key actions and to achieve 4 key objectives that the partnership have developed and want to build on. None of these will be a surprise. They align with many of the national drivers that exist in many of the national policies, but particularly building the right support in the community, enabling people to have access to housing, community infrastructure, opportunities for employment, and to live in safe spaces, and really to prevent people's needs escalating so that they may have to access hospital or inpatient care. And we're doing really well in Kent and Medway around this. Our hospital avoidance admission for people with a learning disability and autistic people is really, really good. We do still have a number of people who are in hospital requiring discharge, and we're working hard to ensure that that happens. We really want to close the gap in terms of physical and mental health outcomes. So really keen to see how we can align with the public health and population health actions that are taking place in Kent and Medway. We really want to increase young people's involvement in their planning for their adulthood and to grow their sense of autonomy and independence in terms of opportunities, so that we give people in the future greater opportunities than people may have at the moment. And then finally, improving access to education and training across all ages and support for people into employment and job opportunities. And again, there's some work happening in parallel in the children's space that we're aligned to around those opportunities as well. So in essence, the strategy has come here today in terms of this briefing paper to kind of set the scene. We're working with we're working with our local population and getting their views and their input into developing the strategy. So one of the key drivers for us in this space is to do things in co-production with people with lived experience, so that it's not just our voices but theirs that inform what we do. And we're undertaking a number of engagement processes at the moment, both in person and online, and we'll continue to do that in the spring, with a view of drafting the strategy in late February, early March, with it going for public consultation and then sign-off towards the end of the spring. What's come out of the conversations that we've had with people with lived experience thus far is that they would like us to really build on the opportunities for them to have good lives and to have access to information, assessment and advice when appropriate, getting the right care and support when required, opportunities for greater security, both in terms of financial housing, having the right people support them at the right time, and that those individuals have the right values and skills and treat them with equality and respect. Being safe and very much having a purpose. So not dissimilar to many of the goals and aspirations that any of us have and that we would have for our family members. We know that the implementation of this strategy, which is quite ambitious, really is reliant on us having a strategic traction within the inequalities prevention and population health agenda to drive improvement and sustain outcomes for this group of our citizens. And we really do need to think about how we use existing resources differently to enable that to happen, recognizing that if we do things differently for people at an earlier point, then we reduce some of the costs and also the impact for people in terms of reaching crisis and having to access more expensive and more restrictive services. So my ask to the group is to note the development of the strategy and to just understand from the group where best that this would be signed off, if it's this group or whether there's a subgroup that it needs to go to for sign-off once it's completed. Thank you.
Thank you, Marie. I must say that latter point was the bit that I was looking at the recommendations. I was a little unclear on myself because I think it says there, discuss and agree the governance routes to be taken for monitoring and sign off on the proposed strategy and the timescales required for approval. So I think you described yourself the route that it would get us there through ultimately that going to sign off, I think in late spring, you said, and set out the timetable. I'm wondering, does this not ultimately go back to the statutory partners and their processes, is what I think. So it's for this group to, I think, approve that we're taking it forward, and ultimately it would go back to the statutory partners through their own internal processes to sign off. I'm seeing nods, so good, I got that right, excellent. Great, Marie, thank you, that was very helpful. So having dealt with the rather dull governance stuff, open to any questions on the substance of this. Paul, you indicated. Sorry, I saw Paul Bentley. I saw Paul Bentley first, and I'll come to Paul Bartlett in just a moment. Yeah.
Thanks, Shane. Thanks, Chair. I think this is a really powerful piece of work, so thank you very much. It's super. But two observations, really. I think that the paper in the front sheet, and it slightly goes to your point, Chair, is blank about who round this table would be the lead member. And I do think, despite the clarity on the governance, we should have a lead member. And if you would like a volunteer for that, I'm very happy to put myself forward as the Chief Executive of the ICB. Second point, which is that Leanne and I were in a meeting earlier this week, and I'm in no doubt that this is a group where we have significantly let this group down. When Leanne and I are in a meeting about discharging people from inpatient facilities from this community who have been in there for 14 years, we've got an awful lot of work to do to make this real. So my plea is that whilst I agree this should come back in Q2 of next year, I would like this group to mandate that the work continues despite that formal ratification, because I don't think we should spend another 6 months getting to that point. I think we should crack ahead and do the work.
I can't imagine anybody would disagree with that. That all seems very sensible. And I think equally, if you're willing to be the lead officer on this, then I think that would, or lead member of this group, then that would be fine. But and certainly I'd support that. But I think it will be worth both taking it forward at pace in practice, bringing it back, and certainly I think we would review it in this forum. But I think we need to ensure above all else that the three statutory partners then sign it off and ensure that they all deliver on their respective parts of it. So that seems to me to be sensible. Right, another Paul Bartlett.
Yes, thank you, Chairman. I'm very pleased to hear about, well, not pleased, but encouraged to hear that you said that you've significantly let this group down. I think that's the first step towards improving the outcomes for this group. And I think the key to this is engaging with those who have lived experience. Now, my reading of this report is that the Delivery Partnership Board in 2022 engaged with 39 persons with lived experience, which I think is incredibly low and very disappointing. I think that what needs to happen in the spring and summer, well, the spring, so that we can have a sign-off in the summer, is that a much greater group are engaged with, because this group, those with learning difficulties, it's the parents who have the lived experience of how they navigate the service. And the priorities that you've listed are encouraging, but I think the key is ensuring that those affected, the parents of those groups, are thoroughly supported in navigating, because often at the moment it just requires sheer single-minded determinations from the parent groups in order to properly access the services that they need. So 39 in the lived experience group is too low, and what I'm asking is assurance that you'll be expanding that to a much greater number. Thank you, Chair.
Thank you. What I would suggest is that, again, I'll take a few questions in the round, and then if we come back to you, Marie, at the end of that. Now, I have seen, gosh, I'm starting to see a few, actually. So, right, I think John was next. I'd seen Shane, and Caroline, Sedi, yes, and yeah, absolutely. Great. Okay, right, where did I start? John.
In which case, Roger, I was going to ask three things, but I'll only do one because I'm conscious of that long line after me. So I just think on the autism, just to build on Paul's point, in terms of the importance of this, I think the other area that we've undersold is the autism and the ADHD because of the explosion in demand for these services. We had a very powerful patient story or mother story, parent story at our Kent Community Health, John Galston, Chair of West Kent Healthcare Partnership and also Kent Community Health, where her child was at school, and as things are, that child will be waiting 2.5 years for an assessment before you get on to what happens after that. And actually in the adult ADHD, as Marie knows very well, the demand is even greater actually now than it is on the children are waiting up to 3 years, but actually adults, it would be even longer. So I think the severity of, and this is not just a Kent issue, obviously, it is an issue across the country as people become more aware of these things, particularly parents, schools are much better now at spotting this. So I think we shouldn't underplay the enormity of the problem, and therefore we got to work on the solutions and clearly redefining all the pathways and thinking of new innovative ways of dealing with this, rather than, because actually there isn't the capacity out there to just assess people even if you wanted to. So I do think that's a very important strand to hear, which I think is a bit underplayed, Marie, and clearly the delivery of that by the MHLDA Provider Collaborative Board as a vehicle for doing that is going to be really important.
Thank you. I do think that's an extremely important point, and actually I think picking up what we'll come to in a moment, or Marie will no doubt, but I think the point about engagement is a very fair one, though I think the intention very much is that this is recognising that past levels of engagement and co-production have not been what we would want them to be, and so a different approach at this time. But I'll leave you to say that. Right, I was next. I think Shane was next.
Thank you very much, Chair. I welcome the strategy. I have a lot of sympathy with what Paul said. I think this needs to be a dynamic document based on the fact that we need to do this in a way of co-production. It's the only way this is going to succeed. But I think the main tenets clearly are there. What I have a problem with, I suppose, is the disconnect between Appendix 2 and 3 in a way. There's a very, it's very good vision and it works quite well. And then the delivery body seems, the partnership seems to be quite limited and probably historic in its sense. You spent some time talking about homes and jobs as one of the key 4 tenets here that are required to work, but nothing from Job Centre Plus, nothing from the, and there doesn't seem to be anyone there that could help in that regard from the Department for Work and Pensions, for example, in that regard, and similarly with housing. There isn't a sort of magic wand that partnership's going to be able to do to say, right, we command in this particular way. It's a bigger problem. So you're going to need to have the right voices around the table. So my question probably is that, do you have the right bodies around the table there to make those decisions or ask them to make those decisions, because it's a principle of subsidiarity, and to enable you to deliver this vision? Because you're missing probably a good quarter of the people you need around the table at least.
Thank you. Now, I think I'd seen, trying to get my order right, I think I'd seen Sedi. Sorry? Did you have a point, Sedi? I thought you did.
Thank you. Just very, very quickly, conscious of time. So very supportive. I'd like, and it may well come out of the delivery plans, but around transition, clearly in terms of meeting our ICB outcomes, the plan ticks a lot of boxes. I'm pleased to see reference to housing there, to education, because these are going to be important sectors that need to make their own contribution, because there are people who have been in assessment and treatment units for many years who there's nowhere for them to move to. But the thing that in my experience, having worked in this sector for many years previously, transition is a huge area. So just, you're nodding, you know this. That's why I was almost going to say I wasn't going to make that point, but Roger forced me. Thank you.
And you have. Right, and I've got Caroline, I've got Christine. I think, is that it? I think so, yeah. Right, Caroline first.
Thank you very much. And I just really welcome the strategy. I also welcome Paul Bentley's comment around that implementation we won't wait for sign-off, because I think there is a bit of strategy fatigue in that we have been thinking, acknowledging the problems for a long time, but we aren't really seeing changes. So thinking particularly about patients that I see who are waiting for diagnoses, they're not managing to access support and help that they actually need while they're waiting. And there is a lot of, so specifically thinking about autism and ADHD, I hear from a lot of parents who are waiting for a diagnosis because they feel that's going to open a door to access help, particularly around education. And I really feel that there's been some work at the ICB that's been really helpful in terms of actually putting in the support before the diagnosis is made, working with education, implementing that practical support that parents need. And I would really hope that that can continue, because currently I've got many patients who are waiting for diagnoses and are growing up and actually leaving the education system, or they've left the education system by force, probably the wrong word, but I think the parents do feel it is that way, because they can't actually get into school and stay in school. So there are huge problems around the waiting list. And so I noted in the report the talk about the reprocurement of some of the services for our CAM, children and young people mental health services. I remember the last time that happened, there was a promise that the waiting list would be addressed, and they've got significantly larger in that time. So I would really like to see, as part of that reprocurement process, a robust acknowledgement that there is a worsening waiting list, and how is that going to be addressed moving forward. Thank you.
Thank you. And Christine.
Thank you, Chair. I just made a few notes because there was so much I wanted to talk about, but I'll condense it. Thank you, Marie. Yes, I think it's a really good piece of work, and it's a really hard one. It's a difficult one to tackle, because if you meet one autistic person, you just met one autistic person. There's so many different needs there. I just wanted to say also, in terms of providers and providing that support that is necessary for people, we actually support autistic people with complex needs, but actually they have been traumatized by the wrong support in the first place. So I welcome, obviously, to dedicate about prevention, which is so important. So we may have better functioning people going forward if we address all those things. My other question is, how are we going to represent people with complex needs in this? And Paul mentioned it earlier, in terms of having their voices heard. We support a lot of people who cannot speak or have problems communicating. Now, obviously, we have an opportunity to facilitate that communication, but it won't be in the forum that is presented now. So that is one question for me, because this is probably one of the population that may cost you more if we get it wrong. And therefore, they are really, really essential to get on board. And that's the population that we support, of course. I also wanted to ask you if you're also going to present a forum where providers and experts by experience, of course, as well, have an opportunity to share some innovation, new ways forward, because that's exactly what you're talking about. Is there a new way forward? Can we do it differently? And I think there's a lot of expertise out there. So can we harness that opportunity with all those people on board as well? So, thank you.
Thank you. Well, Marie, there's a few points there. If you just pick up whatever you wish to from those things.
I'll try and capture them. So thank you. In terms of engagement, I completely agree. 39 people is not the voice of our population. These are thousands of individuals, which is why we've, as of the beginning of November, we started a further engagement piece of work with people. So we had 90 people in the room with us at a recent event. 60 of those were people with actual lived experience, rather than the professionals being the predominant group in the room. But we had the voices of care providers as well, as Christine's pointed out. And that's just one of the engagement events. We've got an online space that's been running in parallel, and we've had lots of feedback, so we're just collating that from there. And then in the new year, our intention is to go out to people rather than asking people to come to us, for exactly the point that Christine has raised. In terms of going to people in the spaces that they're in, we gather their voices in a more robust way. And we are very much trying to think about how we get the voices of people who can't articulate verbally for themselves, but will have a voice to add in a different way. So we are working that through, Christine, and obviously keen to have colleagues join us in that and to support that. So my intention is, by the time we get to the strategy, it actually will be a co-produced piece of work rather than just a tokenistic representation of people's voices. We're also very keen that it is individuals' voices as well as their families and carers, because those lived experiences are different depending on which bit you inhabit, and so therefore we need to make sure we reflect all of those as well. In terms of your point, John, about the ADHD side of things, I don't want to separate that out, but we do have a statutory duty to individuals who have a learning disability and who are autistic. That's set down in law, which isn't there for those with ADHD at the moment, but that doesn't take away for the fact that we do need to look at our neurodiverse population as a whole as part of this piece of work. So in parallel to the paper, and I haven't articulated it in here, but we've had previous papers around ADHD, we are doing some work around that side of things as well. And just to set the scene, in 12 months, we had a 700% increase in the demand for the adult ADHD pathway, which none of us saw coming. That reflects the demand nationally. So it's not that we weren't anticipating an increase, but we've seen an increase that's significantly greater than we were expecting. So we can't continue to grow a model that's diagnostic-led in the first instance. It won't work, it won't meet people's needs, and your point about support is really key. So the modeling that we're doing at the moment around both the autism and the learning disability pathways, as well as the ADHD pathways, is about support first, and diagnosis being part of that as well. So in our remodeling of around procurement, particularly around the ADHD pathways and the autism pathways, we're looking at increasing the opportunities for people to self-support where that's appropriate, so in terms of self-management, enabling people, because that we know all of that has benefits. Having community support, which is peer-led and lived experience-led, because again, the research tells us that actually having advice, information from people who have similar experiences to you has greater dividend and pays greater outcomes for people. A specialist part of those pathways for those who do need to and require access to diagnosis. And then obviously in relation to our inpatients, we will continue to need to have an inpatient provision for this population, but we're looking for that to be the smallest amount of our provision, so moving our resources to the other ends. And there is a lot of work around that, as people who are sitting in the space will know. I don't know if I've answered all of the questions. Was there anything I've missed? Hopefully I've captured and responded.
I think that captured. Shane.
Oh, my beg your pardon. Yes, in terms of the governance, thank you. So it's really hard to reflect a system interface in a 3D model. It doesn't reflect it in its entirety, and in fact, I've changed the model since I've written the paper. But we do have interface with housing in all of the district and borough councils across Kent and Medway. We've got relationships building around housing and accommodation, because housing was one of our biggest challenges in our community, to enable people to be in the community in the right place. So we have those relationships well established, and we invested in a post that enables that to happen, and so that's their primary focus in driving that. And we've also got those interactions with supported employment and other spaces in terms of jobs as well. But that is our ongoing work, is building those relationships, having people at the table, informing those discussions. So yeah, that governance structure doesn't really reflect the nuances that exist across the relationships and strategic thinking and working. Thank you.
Very good, Marie. Thank you very much. I'm going to move the recommendations, which is that the members of the Integrated Care Partnership are asked to note the plan for delivering a system-wide 3-year strategy for people with learning disability and autistic people living in Kent and Medway by second quarter 2024-25, and to discuss and agree the governance routes to be taken for monitoring and sign-off on the proposed strategy and the timescales required for approval. Is that noted and agreed? Yeah, thank you. And Marie, can I thank you very much? I think we all agree this is a really important area, and one which I think there's a great prospect for continuing to build on the improvements that we've started to make. And thank you very much for that. Great. Right. With some catastrophic chairmanship, we're now well behind time, but I will move us on to our last substantive item, which is the integrated care strategy and the refresh of that. And I know we've got, well, it's reported it's coming down from Anjan, Vincent and James. Sarah, I assume that you'll be, as we discussed, you'll be covering in effect for Anjan on that. I don't know who wants to start. So this is, as we say, clearly we published our original strategy, as everyone recalls, a year ago, December last year. That was under the somewhat forced march requirements of a national mandate to have it done by the end of that year. Vincent and colleagues both got that through at remarkable speed and have been working, and we've been working across the system since then to generate a refreshed version. So I will turn, I don't know, Vincent, do you want to start on this? Clearly it's in the names of all three of you.
Yeah, thanks very much, Roger. And I'm going to just make a couple of points, because I think the paper does speak for itself in terms of the journey that we've been on. But a couple of points I wanted to make is this is the strategy that's owned by the Integrated Care Partnership, so this absolutely is our joint strategy, and we're being asked today to endorse the joint strategy before it goes to the statutory partners across the ICB, Kent County Council and Medway Council for formal approval, which will happen during December and January. But a couple of points just to make. I think when we agreed the interim strategy, we were very conscious that we didn't have sufficient time to undertake consultation and engagement work across the system and with our population. And so we've really taken the time over the last year to ensure that we can address that. And we have looked at a number of different mechanisms to ensure that we can engage and consult with stakeholders, but also, importantly, the people who live across Kent and Medway. So we've had over 2,000 responses to our interim strategy, feedback about how we could improve the strategy, how we could focus our attention around the shared outcomes, but also importantly, how we recognise the context that we're working in terms of the current economic challenges, but also think about how we work together as a system to make the best impact. And so in the strategy that's before you now, you will see that we have specifically also highlighted the areas where we think some of the key indicators that we would want to see in terms of measuring impact, but also you'll see that we have refreshed the strategy to really reflect and take on board the feedback that members of this board and our system and our communities have told us are really important to them. And those are the things that we've highlighted in the shared outcomes. So I hope colleagues can see the difference between the interim strategy and now. We're obviously on a journey where we're engaging with health and wellbeing boards, because this strategy also is the health and wellbeing strategy for Kent County Council, and we're working closely with colleagues in Medway Council so that it aligns with the Medway Health and Wellbeing Plan as well, and that actually we're working together on those shared outcomes. And I really feel we're at a stage where actually the most important thing that we can do next is move on to focus on delivery and really think about how this integrated care partnership works with partners such as our health and care partnerships and our other stakeholders across local authorities, voluntary and community sector, to really think about how we deliver on this strategy and can make a difference through the vision that we've set in the document. So those are the key points that I'll raise at this stage, and happy to invite James and Sarah to add comments as well.
Thank you. Yes, before I call either of them, just one other thing worth mentioning. I've been notified that we are in fact in this meeting not quorate, which has, now the implication or the way to handle this, given that we do need, subject to agreement, to take this through other parts of the process, particularly with the statutory partners, is that I will put in some wording about about it being agreed subject to the comments and views of members of the partnership who've not been able to attend through virtual agreement. That is the advice I have. So I hope that that is acceptable, but I've just been advised of that. So I thought it important to convey that to the meeting straight away. Before we go any further, I know some colleagues want to comment anyway. Can I come to either Sarah or James? I don't know who wishes to come first. Come in first. James, you're indicating, now come to you, Sarah. Is that all right? Thanks.
Yep.
Thanks, Chair. And very, very succinctly, because the context, I think, has already been set out. Medway are fully behind the strategy. It's aligned, as Vincent's already said, to our joint local health wellbeing strategy. We took it to our Health and Wellbeing Board. It was endorsed through that process, and clearly now this final version will then go through our cabinet processes to get signed off. And I just wanted to touch on two quick points. One is outcomes. Vincent's already said it. It is a piece of paper. And I think the nature of this is that it just gives us as agencies and this board the ability to identify what needs to be done to improve outcomes for our population. We've got clear measurements in there for our log frame approach, which will give the partnership board here the ability to look at whether we're doing what we were saying that we're going to do and determine whether we've done it. And the other point, just reflecting on the feedback from people, I think the people have actually shared what their views are about this, Chair, and they have endorsed, I think, the approach that we are taking. So as near as I can understand it, I think it's in a good place. Clearly, it's not just going to be fixed. We will reiterate it as required, but from a Medway perspective, the content of the strategy are fully endorsed.
Thank you, James. And Sarah.
So I will do my best to articulate what Anjan would have said. Certainly he was very clear on three things, I think, from this. The learning through partnership that's come about here, the opportunity to make a difference, and the pride he feels. So learning through partnership, I think Vincent and James have both said how much engagement there has been and widespread community support, which is fantastic. Not least the impressive amount of ownership, particularly from districts to tackle the local health challenges. And I think there's been a huge amount of learning for everybody concerned there. In terms of the opportunity to make a difference, yes, there are major challenges currently and on the horizon. I think going forward, local communities are making sure that voice is really heard and they're given the opportunity to play a key role in both identifying and meeting the needs in conjunction with the VCS alliances and parishes. So it's great that we've got so much partnership work ongoing. That will be, we've talked about some of the outcomes. It's really important when you think about tackling loneliness and helping people to lose weight. They can only be achieved at the required scale if communities come together to help each other. Anjan also mentioned the significant opportunity in terms of the public sector anchors in helping people into work and local businesses through procurement to add social value. So I think that's a really important one alongside scaling up things like making every contact count and our social prescribing work. So I think, as James said, it is the start of a journey. It's a piece of paper. It's not a done a job finished at this point. There is real work for us all to do to continually build on what we've learned already and the good practice that's in place. So the final point that Anjan wanted to make was the pride, I think. The pride he feels in being DPH in such a great system and how he's committed to support the partnership in any way possible. And consequently, he has reordered the public health capacity in order to ensure that we're structured according to providing local support. So we look forward to working with communities to build delivery plans.
Sarah, thank you. And I know very much that is the work that Anjan and you and the team have been doing. So thank you very much for that. Right, I've seen a few colleagues. I've seen Shane, I've seen Claire, I've seen Angela, and I've seen Sally. Okay, Shane.
Thank you very much, Chair. What a difference a year makes. I think this is a much better document. It really is. And the difference is because it was done in the right way in some words, this version. It was engaged with, done with the public, done with partners, and focuses on those key areas. And frankly, it's reflected throughout. The focus on prevention, on subsidiarity, on partnership, on access, listening to staff, which wasn't in the first one, believe it or not. So the difference is clearly there. There'll be bits we're never going to agree on. I'm never going to agree with family hubs with you, Roger. I'm sure you'll be not surprised at that result. But it is a real difference, and I think the point that Vincent made about it now goes down to delivery, and I think that's where we need to get to now. I'm actually disappointed we're not quorate because I thought it would be a good start to the new year just to get this back to the delivery stage. So it's a thank you for listening. But the concerns I had a year ago were not because I had them, but because being on the ground like many others, we knew what they were, and they clearly are there because they're reflected in the strategy. So I think it's a real difference, and I think we now need to just get out there and do it. So thank you.
Shane, thank you, and I agree with almost all of that. So no, thank you for that. And I think in fairness, we have to recognise that a year ago we were working to a timeline that was not our own, and that undoubtedly shaped and constrained things. So, but no, I think there is a huge, and my understanding, I'm obviously take advice on this, is not to be in quorate today is not a complete showstopper. It simply means that we have to ensure that we take the views of all those members who are not able to be here and take those formally into account, and then we can still move it forward to the bits of the formal governance of the statutory partners, and then most importantly, as we're all saying, the delivery side. So no, thank you for that. And I think I then saw Claire was next, I think. Yeah, Claire.
Hi, I'm Claire Cardy. I'm a VCSE sector representative, and I echo what Shane's just said. I think this is a much better piece of work. The level of engagement's really encouraging, and it shows through the document, and some of the comments are really, really helpful. I just want to I feel duty-bound to make an observation about the disconnect with the very admirable aspirations in this document, which I think we can't argue with, and the disconnect with the reality on the ground. So, for example, one of the key themes that was identified in the consultation was support for youth services and youth clubs and youth work, and the cuts in funding and the impact on VCSE, sector organisations and others, community groups. And I know it's it's a very difficult situation, but that for me is a really obvious example, and there are others where the funding cuts and the reduction in funding or short-term funding really doesn't reflect the engagement and the partnership that we're trying to achieve. It's just a reality check, really.
No, and I think clearly I'm not going to abuse my position as chair to play the KCC side of this, if you like. But what I would say as a general comment was certainly from my point of view, and I think a number of my colleagues, when we were looking at some of the drafts, one of the points we made, and I think that it does come in some of the wording, is all this is subject to the fact that all the bodies here, certainly you look at the big statutory bodies, the ICB, Kent County Council, Medway Council, and indeed many others who are involved deeply in this, such as districts and boroughs, we all face these financial constraints. And it was and I was a little bit obsessive actually about saying, when we write this, we've got to acknowledge that we will end up having to make choices and sometimes having to do things we may not wish to do, and it's a little bit of squaring the circle on that. So I think the point's well made, and I would recognise that. Angela.
Yeah, I should have said Angela Harrison, Surrey Borough Council. Thanks, Chair. I a year ago, agreed a skeleton because we quite clearly did not have the time under the hammer to do the sort of consultation that we would have liked. We have now spent a year, and I'd echo the comments that Shane has made. What a difference. I have got a question, though. The proof, yes, is in the delivery, and these sayings are dying out, so I'm going to keep saying. The proof will be in the pudding. And we, because it is us, we have got to put our money where our mouth is. It's not you, it's not them, it's us. It's a partnership, and we've all got a part to play in it. My question is, do the HCPs have enough or the right delegations, memorandum of understandings, whatever the technical terms are, to actually play their full part in this? Thanks.
Thank you. I think I will deftly pass that one over to Vincent. It's a very good question.
Thanks, Councillor Harrison. So I think the direct answer to that question is absolutely around how we build the delivery plans. Some work has already gone on in terms of the role that the ICB has in working with health and care partnerships around delegation, and we've agreed with all 4 health and care partnerships delegation agreements that set out more clearly what their roles are and what their responsibilities are. I know John's here as one of the chairs of a health and care partnership, but just to use one example, in the last year, the ICB delegates what I call a reasonably small amount of money in the scheme of things to support health and care partnerships to work at a place and neighbourhood level to help reduce health inequalities. And that resource that we allocate, which is about £5.9 million a year, is really targeted at how we can focus on some of those core 20+5 priorities that impact on people's health and well-being. So that's just one example, but I think we need to go further. I know that Anjan and Sarah have talked about the work that we've done over the last year with district and borough colleagues to really be clear about the improvement plans that they have in place. And I think the challenge for us is how we bring all of those plans together as a system, but also really think about how we maximise on the utilisation of the resources we have available to support our populations. And within that, also think about where there are opportunities for people to also take personal responsibility as well. And I think there's more work to do around that, and that should come through in the delivery plans that we want to develop with our health and care partnerships over the next period.
Thank you. And I think that's absolutely right, both in terms of what Vincent was saying there, indeed Sarah emphasised it too, that a lot of work has gone into building those links across different parts of the system, to use that term, which means that we are, I think, in a much better place to be able to take the aims of this strategy and then find all sorts of ways in which we can work to deliver that. And I think we're in, again, a much better place than we were a year ago. Sally.
I think actually I'm going to echo some of the points made by Shane and by Claire. My name's Sally Williamson, I'm the VCSE or one of the VCSE reps. Certainly in terms of the children and young people, which is my area of expertise, we've come a massive distance in this. And I can see even from the first draft, this is much better reflects what we're hearing on the ground about priorities, which is wonderful. I would agree with Claire, there is a real risk around disconnect. You know, when we look at the family hub model and when we look at the loss of use services, there are real challenges in delivering this without those networks in place. And I guess it's just from me saying, if we agree this, we have to have some kind of, we need to ensure the governance is right to make sure that the partners around the table use this as the blueprint on which they build their priorities. We can't have a situation where the priorities of KCC or the ICB are running separately to this. If this is what we all sign up to, then we do that across the board. And it's just kind of, from my point of view, having that explicit and saying we all commit to these being the priorities going forward across all of our organisations.
Yep. No, I think that is implicit. I mean, the one thing I would say is that all those bodies end up juggling a whole number of statutory and other requirements on them within a financial envelope that none of us controls. And that's, I think, where the challenge lies. But I think that's why, again, as I say, I was very keen to try and work in some wording that sought to recognise the realities that we're all dealing with, whilst emphasising these are the things we should make a priority. So, no, thank you, Sally. Was there anyone else? Christine?
Yes, thank you, Chair. I just wanted to perhaps mention the big white elephant in the room, and Claire mentioned it, is that the ambitions of this group is brilliant, and I think some of the strategies are excellent going forward. It will improve lives, but your envelope has just gone smaller, much smaller, because going forward, the cost to provide this is going to be much more as well, especially with the inflation, the increase in costs altogether, and also the biggest hike ever in the national living wage, which is great, but who's going to pay for it? So I don't think we can keep our eye off that ball, because otherwise our ambitions are just going to fall flat. And I think our priority is to keep the ambitions, but if we just focused on cutting, we're never going to get there. So my question is, do we have our eye on the ball, on that very important ball, that quality and our ambitions come with, what it costs as well, and we need to meet that cost. So where are we going to shout, down or up? That's my question.
Well, I can only speak for my own organisation, but the amount of shouting up that we've done has been pretty considerable. And in fact, if anybody who listened to the Today programme this morning would have heard the chairman of the County Council's network, our trade union, on exactly those sort of issues. And in particular, actually, if I may say, one thing which we've all made a lot of noise about is children's services and the particular demands that there are in that area, which I guess ties in very much to objective one of this. So, but I think the truth is we have to operate within the constraints we have, but equally seek to, and I think a lot of my thinking on this has been about the ways in which we try to marshal our collective resources to ensure that we can deliver together what we couldn't deliver singly, because that is going to be one of the most effective ways of dealing with what I suspect is going to remain a pretty tight environment for all of us for some time to come. Govinda.
Just a quick point. I'm glad, I think there's consensus around the strategy in terms of what it looks like compared to last year. I just feel all of us, be it the volunteer community sector, be it the police, be it local authorities, I think we've got a key role to play in terms of sharing this information now as well, because otherwise we can end up just being a talking shop, talking to ourselves. This is only going to work if we can get this out on the ground, serving, working with the communities that we serve. And so I feel it is really important. There's a clear communication strategy behind this as well, and it's tailored towards the different groups and organisations that we work with on the ground. So hopefully that's something that could be looked about outside of this meeting.
Yeah, I think that's absolutely right, and that builds on the work, some of the engagement work that was already done in building towards this, and the intention is very much to keep taking that forward. Is there anyone else? In which case, before we move to recommendation, now I'm just going to check a point in relation to, can I just ask Mike or other officers, is our not being quorate related to elected members, and particularly because we don't have, and particularly from Medway, is that what makes us not quorate? Sorry? Right, because we have here Councillor Adam Price. Adam, can you just speak into the microphone so anybody can hear on the webcast? Right, yes, so we were quorate without even knowing it. There you go. So, yes. Yes. So could you just speak into the microphone and welcome.
That's not, yes, Chair, I'm sorry that I was late, which I had given prior warning, and I'm pleased that this has given me the opportunity to make my introductions because I missed it earlier. Thank you.
And it's Councillor Adam Price, lead member for Children's Services in Medway Council. So with that, we can rejoice in the fact that we are in fact quorate, and I can therefore go back to the original recommendations, which I will read out. So the ICP is asked to note the extensive engagement in developing the integrated care strategy, the positive response to the first draft, and the changes that have been made following stakeholder feedback, and to recommend the strategy for approval by Medway Council, NHS Kent and Medway, and Kent County Council. By the quorate partnership, is that agreed? Thank you all very much. Right, I think we finally move to any other business. I'm sorry, I'm just checking I'm not missing anything. Is there any other business? No. Then I believe I can, at that point, close the meeting. Thank you all very much.